These are my unbiased slides here. So what we're going to talk about is, there's multiple different ways to attack iliac CTOs and all the tools. Everybody has different techniques. Everybody has their algorithm, how to approach it. Some of the techniques for the reentry part I think is important to discover. What to look out for, and problem solving, which I'll show you a case of oh crap moment that we kind of figured out. Thoughts on reentry for me, it's not the first step. It's usually when I failed retrograde first, then antegrade, and then I go to reentry device. A lot of us that are doing PAD and aortoiliac, you have comfort level with a lot of different reentry devices. There's a few main ones, and I primarily use the Outback, which I'll show you. And there's some nuances too as well. So in most cases for those iliac CTOs, retrograde for me is the first option. It's your average patient, the ABIs, everything was evaluated, stress studies. And of course, half of my patients are CO2 because in the Midwest, they all have some level of kidney disease. So it's a nice, beautiful CO2 angiogram, which everybody loves, and call it the CO2 angiogram. And you see that the occlusion on the right side, common external and internal, on the initial picture. So we have a long length of occlusion. And, sometimes I, of course, by training, use ultrasound on everything. However, when you're heavily calcified, you actually have a really good roadmap just to stick it under floor. You can see there's also SFA occlusion as well on the same side. So a patient has SFA CTO, as you can see here, so long length occlusion. So on this patient here, I have access on both sides, usually for a complete iliac occlusion. It's always good to have a target, so this is the path you kind of want to take. Sometimes, you access, contrary to most things in life, I think keeping it small is better here. Usually just a micropuncture needle, an 018 wire, and the inner of the micropuncture sometimes is all I have to get across. And it does work in many situations. And that's just a nitrix wire which forms a little loop, and sometimes you worry about loops, but if it follows straight, you might find yourself getting up into the aorta, and it's always good to get your hands out of the picture, unlike in this case. Once you get up there, obviously the next step is confirming that you're in there. Do your very, very dilute injections. Plan it out. Now you do see that there is a little bit of internal, it just wasn't filling before. We stent across it as usual, and then same time you can treat the same leg as well if you want to. It depends on how you want to approach that. Can we just balloon it? I think we've all discovered that no, stenting is better. And the next step is sometimes that retrograde doesn't work. So you have a patient who wants to get back on the golf course, and this is your picture. You have an occlusion. And also, you see that there's reconstitution of the vessels with just kind of dilute flow because of what it is. If you don't know what Throckmorton sign is, you should Google it when you're not at work. It's a radiological sign. But nevertheless, tried from the retrograde direction. As you can see, formed a loop, however, would not cross the final cap to get into the aorta. So then from above, decided to get a glide wire and try to get across. There's a patent distal external on that side. And we like using snares a lot. I think it's a great tool to have for target, either a catheter or a snare. And what you do is you try to get a wire, and sometimes you do go a little subminimal, but you can pop back in. Now the question, we have a lot of trainees and say, how do you know you're subminimal? And you tell them you just know. But then you typically just watch your wire path, as you see in the leg here. When it curves and it waves, you're pretty much subminimal. If you think you're subminimal, you probably are subminimal. And that's okay. The goal is you get back in. Once it pops back in, snared it, get across, make your decision for what kind of stents you're going to use, and you stent it. So that's kind of great. And when that fails, why are CTOs so difficult? It's the same problem that we have in the fem-pop area. It's the cap above and below. Fadi has talked about the C-tops, and I think there's some relevance to that in the iliacs as well. So the way your wire goes, it depends on the cap itself. So in those situations when you can't go antegrade or retrograde, as in this 69-year-old had a lot of comorbidities, claudication that's getting worse, and you have this picture. And I think most of you can assume that catheter on the right there, that's an angle catheter and a try-to-go glide wire, it was not staying luminal. So at that point, I like to put the Outback in there. It's a 6 French. It's nice because you're making it's a 014 wire that you puncture across with. So having a target on the other side with that reverse curve catheter helps you also know where you want to get back in. And there's a point to that, and I'll show you. I drew this crude drawing yesterday. I think it turned out pretty well, if you guys can give me some credit. But the point being that when you have the CTO, it really matters where you re-enter. You do not want to raise that bifurcation above that crotch unless you have to. But having a target placed right in that area, the mouse doesn't show up here, sorry, really helps you nail it in a good spot where you're not going to raise that bifurcation. You're not going to create a plane that's higher than the native lumen on the other side. So I think that's a very important consideration. In this case, re-entered, and I like to snare from the other side so I know exactly where I'm going. Gives me a good tight rail to put a sheath up as well. And then I push the catheter back up. That is not where I deployed the stents. That was just pre-planning, not to scare anybody. But it does matter. Don't raise the bifurcation unless you have to. It creates problems for the next intervention. So trying to land it perfectly, either with IVUS or just angiographically, it's very important. So, and then, try not to extend below the inguinal ligament. I think we all know that, unless you absolutely have to, which I'm not sure what those cases would be. It's very important, especially when you're teaching people. Common femoral artery is a very special place. You shouldn't intervene unless you have to. Sometimes you get in situations where you have distal aortic and iliac disease, like we've talked about in these other cases. And how do you approach that? Well, depends on how bad it is, what you're using. You can either do endograft, you can do small cuff, you can do bare metal stent if you have small aorta. The vessel characteristics matter. Remember that your sheets can become occlusive. You don't want to become thrombotic. This was a little bit of a learning lesson. It's a 68-year-old female, half-block claudication for many years. Outside hospital, our colleagues showed us on the angio that there was severe calcified aorta and a CTO of the right iliac artery. This is the picture. And you can see there's a lot of disease in that aorta as well, a lot of calcifications, which we did check the pressures on that. It was significant. So, as any other case, we approached it, bilateral access. The right side, surprisingly, I thought flew right up and felt pretty good about myself. And as you can see here on that catheter, it's not in the lumen. That's subintimal. You're on the outside edge of that calcified vessel. So re-entered, came back a little bit, re-entered, had a snare on the other side, thought it was pretty good, and then was about to plan for stenting, and this is the picture. So that's not a good picture. You have a big subintimal dissection area there. So now the question is, how do you fix this? So what I noticed on this picture when you mag up is, I don't know if this mouse will work well, but there is kind of a normal luminal segment here, as you can see here. So then the plan was, well, we can put another reverse curve catheter kind of into this part of it and try to re-enter here, which if you're able to follow, that's kind of what we did. Here's the reverse curve catheter, a little bit just into that nub that we saw, and outbacked right into a snare through that reverse curve catheter, which then, as you can see on the next picture, we were able to get snared access, balloon that segment to get a catheter up. And we confirmed that we were in that same lumen by injecting down the other side. Now the question is, you have a big flap in that distal aorta, what do you do? So what we came up with, and I'm sure other people have tried this, is from that native luminal left side, when we have a snared access, is basically rode that sheath up the right side with that snared wire. And as you can see here, this is how we did that, and stayed in the luminal part of the aorta. Subsequent to that, was able to get a catheter up, stent a VBX, and also put a bare metal stent in that distal aorta, and actually the pressures dropped to not significant anymore. It wasn't the greatest picture, but the iliacs look much better. She actually did fantastic for 2 years, follow her up every 6 months, and doing great. So I think you have to be improvisational in these situations. Other options, like we talked about already, lithoplasty, reimbursements are important. And I think we talked about this before, is always have your backup plans, have covered stents ready. You don't want to run into these situations. Also with the radial access talk, that was a great talk as well. I have a friend who has some PTSD from doing radial and not having covered stent ready in the groin. So, you got to be careful in those situations. Even if you're going from the arm, which is a good option, have your groin access ready to go if needed. Thank you very much.